globally, ICPCN has estimated that 21 million children need supportive care all over the globe. And the neuropsychiatric problem is going to be the #1 cause. And when we deal with children with autism and conditions like ADHD, we just forget them at all. Probably, I don't think anybody in this hall are peaceful enough or are experts in managing children with autism and ADHD. And whenever they come to us, we just scribble something and we try to send them away because they are so probably destructive, hyperactive, and majority of the pediatricians don't want to entertain them. If we look at the Indian scenario, again we know that there's a high burden of chronic debilitating diseases in our country, but we do not have a disease-specific history, and hence the true burden is not known. And I had our own statistics from my department. Around 4.5% of children getting admitted in our wards need supportive care, which comes to around 1,200 children per year. And if you look at the ICU admissions, about more than 1/3 of children getting admitted in our tertiary care center need palliative care, which comes to around 450 per year. And I'm sure this will be almost similar if you take any major hospitals in the state or in any country. And what are the common disorders we need palliative care? The #1 is a neurological, a huge list of conditions: cerebral palsy, neurodegenerative disorders, inborn errors of metabolism, intravenous infections, post-meningoencephalitis sequelae, space-occupying lesions of the brain, hydrocephalus, various syndromes. And how do they manifest? Yes, you name a symptom, they have it. Uncontrolled seizures, varying tone, both hyper and hypotonias, contractures, difficulty in feeding, gastroesophageal reflux, visual impairment, auditory impairment, nutrition deficiency, both macro and micronutrient deficiencies. The muscle disorders, yes, both the congenital and the metabolic myopathies, and the various muscular dystrophies, the Duchenne muscular dystrophy, Becker muscular dystrophy, Morrison negative, so many types of dystrophies. Generally, they have a very good mentation, but they have got significant hypotonia, and most of them are either bedridden or are able just to walk. They have repeated aspirations, and finally they become oxygen dependent, and death occurs secondary to respiratory failure. Chronic kidney disease. How do they manifest? Is the triad of short stature, anemia, and hypertension. I repeat, I think any child coming to us with a triad of short stature, anemia, and hypertension, I think we should always make it a point to roll out chronic kidney disease. Is again rheumatoid arthritis, suffering from pain, and with various other morbidities like contractures, joint stiffness, and varying degrees of physical and functional dependence. Cardiac disorders, the major complex congenital heart disease in whom even a palliative surgery is not possible, or in whom only a palliative surgery is possible, and the various myopathies, the obstructive, the constrictive myopathy, dilated cardiomyopathy, as well as hypertrophic cardiomyopathy, in whom only supportive care is possible. How do they manifest? Yes, either they present as cardiac failure, or they present as recurrent cyanotic spells. They are prone to have recurrent respiratory infections. The quality of life is significantly compromised, and again, death coming early because of cardiopulmonary failure. The respiratory disorders, chronic lung disorders of infancy is high in the list. Nowadays, many preterm babies are salvaged thanks to surfactant, but at least some of them land up with chronic lung disease of infancy. Nowadays, we have got very good antibiotics to take care of the respiratory infections due to bacteria, but virus taken the role, and there are a lot of cases with interstitial lung disease secondary to viral infections, cystic fibrosis, and conditions like bronchiectasis. Yes, they do suffer from persistent tachypnea, persistent dyspnea. Finally, they also become oxygen dependent, and death secondary to respiratory failure. Yes, The chronic liver disorders, cirrhosis of liver with portal hypertension, second hepatitis B, hepatitis C, Wilson disease, and again biliary atresia, manifesting as jaundice, anemia, bleeding manifestations, and again death secondary to hepatic failure. Yes, the list is endless. A lot of hematologic disorders, sickle cell anemia and thalassemia, varying forms of skeletal dysplasias. And what about newborns? Newborn baby with severe respiratory distress leading on to hypoxic ischemic encephalopathy, Meconic aspiration syndromes, inborn errors of metabolism, major malformations. They need support. And what do high-risk pregnancies? A young mother undergoing an ultrasound by 5 months for the antenatal scan, the radiologist is giving a report of major malformations of the intrauterine fetus. Do they need support? Yes, definitely. And what are other issues? The problem in the parents, most of them are depressed, anxious, and probably the most important question they ask us is, what will happen to my child after my death? Who will look after my baby? And many a time, the problems in the sibling goes unnoticed. They have got poor school performance, poor self-esteem, and most of the time they are socially isolated. Yes, they too suffer from a lot of social issues. There are intrafamilial conflicts, and in our own data showed that in about 14% of cases, the father just abandoned the family. They have got poor extended family support, and they have got social isolation, and they have got a lot of financial problems. So, to sum up, a child with chronic disability has got multiple comorbid factors. Their lifespan is limited, but at the same time, it is prolonged, going for years, and they are completely dependent. When such a child is taken to hospitals, again, it was mentioned in the morning, they had to face a lot of barriers. We have got all the major specialties in almost in all the major hospitals, but all of them give a disease-oriented treatment. There is patient overload, so that we cannot provide quality time for the care of such a child. We've got all the specialists, neurologists, cardiologists, gastroenterologists, hepatologists, liver transplant specialists, but all of them are working at their own independence, their own areas, and their own timings. And as soon as the acute care is over, the patient is discharged. There's no continued treatment at home, and there is no psychological or social support. So having discussed the problems, what's the solution? Whenever we don't have a solution, we innovate. Yes, we innovated, we integrated. We collaborated with Panim India, thanks to Rajagopal sir, and see the result. We could establish a comprehensive multidisciplinary clinic in our own department with all the with a full team of palliative care doctors, pediatrician, neurologists, physiatrists, physiotherapists, psychosocial worker, psychologists, occupational therapists, and staff nurse and volunteers. What are our goals? Yes, we focus in continuing the care, management of the symptoms, support to the family, proper communication of the disease and the treatment, shared decision making, and the grief and bereavement support whenever indicated. How do we function? As soon as the child is registered, we look into we take a detailed history, assess the child and the family comprehensively. We look into the physical and the functional abilities, the psychological problems, social and the financial issues are addressed. About the service provided, we provide regular physiotherapy, and the caregiver is empowered so that he can continue the physiotherapy at his home. We focus on the activities of daily living. All the drugs that is not available in the pharmacy is given free of cost. Nutrition supplementation is given both macronutrients and micronutrients. We hold a series of counseling sessions. Traveling allowance is given to those who are extremely poor so that they can visit the clinic. Education support is given to the child if needed, and also for the sibling. And also we continue with the home care provided they are in the home care area of Pallium India. Now let us come back to the real stories. The 3-year-old child with SMA had recurrent respiratory infections. There are multiple hospital visits, and whenever the child had a respiratory infection, he was getting referred to our own hospital. Actually, he was staying around 100 kilometers away. So this and again they had severe financial crisis. They were socially isolated. The mother was thoroughly depressed, a young mother, and she told me that she has not seen her husband for the past 2 years. Whenever he was thinking of coming to the hometown, he will think of the remaining 10 or 20,000 rupees travel expenses, and he will spare it for the baby's care. So does such a child need ICU care? Does he need IV antibiotics? And what should be the mode of care here? Yes, we had a proper communication with the mother and all other caregivers. We took a decision not to admit him ICU. So we shifted him out of the ICU. We did not have any cali, all his veins are thrombosed. So we just put him on oral antibiotics, and he was drowsy, and we put him on hypodermoclysis, subcutaneous infusion of fluids, and nebulization with salbutamol, and a very small dose of morphine and midazolam for rest. But to our surprise, actually he came back to life. Actually, we thought of giving supportive care, and the family was ready to accept even the terminal event. But he came back to life, and he was discharged from the hospital on home oxygen, and at present he is on home oxygen therapy with nebulization and a very small dose of morphine, which keeps him active as well as peaceful. And last week, mother called me. She was very happy, and they have not visited even a local hospital for the past 6 months. And she told me that her husband will be coming soon. And I think again we have to play a major role here, because it's a condition of SMA, which is autosomal recessive condition, so they can recur in the next pregnancy. So we had to advise the couple to proceed with the next pregnancy and to go for antenatal counseling at the appropriate time. The second baby, 1-year-old child with biliary atresia. So again, I told you, child had cirrhosis with portal hypertension, admitted with a hematemesis in our ICU. You can think of a young, enthusiastic PG, a postgraduate PG, jumping onto such a child, aggressively managing the liver failure. Yes, the child was given vitamin K, repeated transfusions, and the blood was sent for all the investigations, LFT, RFT, PTA, PTT, the viral markers, and gastro concentration was done, thinking about liver transplantation. But they failed to communicate with the family appropriately. So next day, when I saw the child, I intervened with the caregivers, actually, and I had a proper communication. Actually, they had visited all the specialists in South Kerala, pediatric surgeon, various pediatricians, hepatologists, and even transplantation specialists. And all of them had ruled out the possibility of a liver transplant in this baby. So we took a shared decision of no active intervention. All the symptoms are properly managed, and the only desire the mother had was to feed the baby. So I just removed the rails tube, asked the mother to feed the baby. The baby fed at her breast directly. Baby had a good sleep. Mother was relieved of her distress, and baby had a peaceful death in our hospital itself. Next baby, just 2.5-month-old baby with a chronic renal failure. Yes, again admitted with severe respiratory distress, severe anemia, and marked acidosis. But none of the doctors could go for a supportive therapy. Actually, baby underwent repeated IV cannulations, and when all the veins are thrombosed, they went for a bilateral venous cut down, and sorry to say that baby had a horrible death because somebody gave false hope of renal transplantation. Baby had probably a very bad death in our ICU. But everybody failed to accept that probably renal transplantation was not possible in this kid, because even the best of the centers in the globe, at least the baby should be at least 8 kg and they should be at least 6 months old to go for renal transplantation. And the last case, case of Digeos syndrome, the fate of this baby actually depends upon the various associations with this, and at present child is under our follow-up and we'll decide the further treatment based on his evaluation. Yes, we do have parent support group and we do conduct family get-together every year. They come in large groups, forget all their miseries, dance and sing. Did he help the child? Yes. So there was better understanding of the illness. We could teach the methods of rehabilitation and we could provide quality social support along with medical treatment. And the most important, we could discontinue the futile treatment options. Yes, it did help the family. The days of hospitalization was reduced. We could revamp the family support system. There was significant improvement in the care of the siblings, and we could make the parents and families accept the illness. And I think in a larger canvas, I think there's high time the Indian Association of Palliative Care should associate with Indian Academy of Pediatrics. So to conclude, with advancing medical care, a lot of children need supportive care, and comprehensive multidisciplinary clinics should be established in all the major centers. The palliative care should be included in the medical curriculum, and whenever possible, association between government and non-government organizations will be of great benefit. Yes, he had a dream, and through hard work and determination, he could accomplish it. And what would we people? Yes, all of us have dreams. And what would these poor kids and the families? They too have kids. And I strongly believe that it is our primary duty and responsibility to help them so that at least some of their dreams come true. And what can we do for that? Yes, I think let us be friends with them. Let us walk beside them. So thank you. I think this is our great pediatric palliative care team from State Hospital. On behalf of all of us, may again bid you a great thank you. Thank you.